The topic is navigating the thoracic maze, anesthesia for high-risk patients.
She's a 78-year-old patient who came with right-sided pleural effusion. He has been having a ICD since a long time, but the pleural fluid drain has not reduced. Therefore, today we are planning a thoracoscopic drainage with adhesivolysis with a pleural biopsy and SOS fluorodesis. Since this patient is high risk for general anesthesia, he is being operated under only plain thoracic epidural anesthesia, and you can see that although I have started mobilizing between the lung and the pleura, the patient is absolutely comfortable only under plain thoracic epidural. You can also appreciate that I am quite comfortable to do this mobilization although the patient is spontaneously breathing and the lung is partially collapsed. The patient's vital parameters will now be explained by Dr. Yatin Khairnar, the anesthetist.
As he is very high risk to do it under general anesthesia. The patient's baseline saturation was around 88 or so, and that too on 4 liter of oxygen. So our plan was to do this case under plain epidural, thoracic epidural anesthesia. After explaining everything to the patient's relative, I did thoracic epidural. I did insert at T4 T5 level. After this anesthesia, you all as seeing how the patient is doing well, and there is no issue. While patient is hypertensive since 40 years, hypothyroid is 25 years, but plain epidural anesthesia definitely the vitals remains very stable. There is not much of a drop in blood pressure. Vitals are so well maintained. Pulse, blood pressure, saturation also you saw. Now it is improved as more of the component was pleuritic chest pain to the patient also. This is the epidural. Using xylocaine and bupivacaine. Thank you.
So before I begin, I would like to talk briefly about thoracic surgery. So previously thoracic lung surgeries, they were open thoracotomies with patient in prone position. But as the advances in surgical approach and technique, it is started being done under lateral decubitus position. And with more advances in surgical techniques and introduction of minimally invasive surgeries, now it is being done under video assisted thoracic guidance. As we see, the patient after induction is positioned in lateral decubitus with preserving the pressure points. So this is a conventional anesthesia which we give for thoracic surgeries, which is general anesthesia. Many a times it is associated with regional anesthesia to reduce the requirements of general anesthesia. So if we see, while inhalational anesthesia was introduced in 1840s, it took approximately 100 years before the significant progress was made in developing anesthesia technique for thoracic surgery. So in 1949, Eric Carlens introduced Carlin tubes, which were primarily used for bronchospirometry. These were made up of PVC, and there was notch, if you can see here, projection, which used to prevent the tube going more deep and avoiding the single lung ventilation. So with more advances, White and Robert Shaw modified these tubes by increasing the internal diameter of these tubes for easy ventilation and suctioning. Present day, the tubes which we use are White and Robert Shaw tubes. So this is how we isolate the lung for thoracic surgeries so that the lung which is to be operated is not ventilated and it's easy for surgeon to operate on that lung. There are other modalities of isolating the lungs which has use of urn blocker. In that you can isolate the lung with the help of urn blocker, EZ blocker, and for pediatric patients we can use these Fogarty catheters. So this is how the tube is placed. The lung is isolated. Only the lung which is to be operated is kept non-ventilated. So this is how the EZ blocker is placed, and the lung which we want to ventilate will be only connected to the closed circuit. This is how tube placement is there. Here on fiber optic scope, you will see this. So these all three lung isolation technique requires fiber optic bronchoscopy. So this is conventional way of giving anesthesia for thoracic surgeries. But what about high risk patients? So these patients are patients with severe cardiopulmonary disease. So patients with coronary heart disease, cardiac failure. There are patients who have severe pulmonary dysfunction, which includes severe pulmonary hypertension, bilateral emphysema, interstitial lung disease, cystic fibrosis, and severe bronchiectasis. So primarily these all patients with poor lung function have FEV1 less than 60% and DLCO less than 60%. Additional comorbidities make it more risky. So these patients, if you induce with general anesthesia, there are high chances of morbidity and mortality, and more likely patient goes on ventilator. So to avoid this, there is technique which there is no other option. In such scenarios, regional anesthesia serves as the viable alternative, enabling the procedure to be conducted safely while minimizing the perioperative morbidity and mortality. So it is also called as NIVATs or tubeless VATs. So there is more benefit to it as there is avoidance of airway and oropharyngeal trauma. As we all know, double lumen tube is more thicker. There is avoidance of mechanical ventilation and there is enhanced patient outcome with this regional anesthesia. So what are these regional anesthesia techniques for NIVATs? It includes cervical epidural anesthesia, thoracic epidural anesthesia, paravertebral blocks, intercostal nerve blocks, erector spinae nerve plane block, serratus anterior plane block, pectoralis nerve block, local vagal blockade, and injection of local anesthetic at the site of trocar insertion. Now, presently, gold standard for all these cases is thoracic epidural anesthesia. So, what all procedures we do under NI-VAT surgery, that is tubeless VAT surgery. These procedures, almost everything you can do under regional anesthesia, whatever been is done under general anesthesia, ranging from drainage of pleural effusion to simple ICD insertion to pleural biopsy to pneumonectomy, lobectomy, and segmentectomy. And even mediastinal surgeries like pericardiectomy, thymectomy, and tracheal resection can be done under regional anesthesia. So this slide represents the thoracic dermatomes, which from T1 till T10. So we have to block at least T1 to T9 to have adequate anesthesia to the thoracic region. Now coming to the spine, if we see the thoracic vertebrae, the spinous processes are very much steep, angled here. So putting a thoracic epidural in these patients is quite difficult task, which is eased by giving the patient a proper flexion position. So what happens once we give the proper flexion to the patient? If you see, if the patient is sitting erect, you see this interlaminar space, which is very much reduced. And once a proper flexion is achieved, this interlaminar space opens up. So thoracic epidural anesthesia, this can be given by a landmark guided technique or by using the USG guidance. If we see after the patient is positioned, I'll come down directly to USG guided thoracic epidural insertion. So patient can be positioned in sitting as well as lateral decubitus. You can put the thoracic epidural. The probe which we use is high frequency curved or linear probe. In thinner patients, I would recommend to use linear probe, but while obese patients, we do require to see deeper structures, so curved probe is preferred. So once the patient is positioned in proper flexion, transverse view is used. So the transducer is placed transversely to mark the midline. In many obese patients, it's very difficult to mark the spinous process or feel the spinous process. So this USG machine does help us to mark the midline. And once the midline is marked, this is how what we will get. See here the transducer is placed in transverse position and the structure which you see here is this is the spinous process, two transverse processes you can see a rib and a pleura. So after the midline is marked, see this picture I've taken for just to know that marking the midline in certain patients is very difficult. There are certain anatomical abnormalities like scoliosis. So it does help that. So what USG helps us in determining is first marking the midline. Once the midline is marked, this transducer is placed longitudinally just lateral to the marked midline, and the structures which you see are the laminas. So here you will get the USG picture of like this. There are laminas and this is the interlaminar space. So you get to know the midline, you get to know the depth of space and the location of the interlaminar space with the help of USG. So once this is marked, keeping the probe in longitudinal direction, a needle is inserted from cephalate towards cephalic region. So while inserting the needle, the insertion will be 0.5 centimeter away from the midline and around 1 to 2 centimeter below the interlaminar plane because the vertebral spinous process at thoracic region are steep. So it gives us a easy way to give the angle to the needle so as we can enter the interlaminar space. And the medial to lateral, lateral to medial angle should not be very much acute because if the angle is acute, the high chance of needle crossing the midline missing the epidural space and entering the paravertebral muscles or sometimes pleura, and it will give false impression of loss of resistance and the epidural space. So the angle should be reduced. It should be very minimum. The angle which from cephalate to caudate should be around 50 to 60 degree to enter properly into the epidural space. So once the needle trajectory we have marked and we enter at around 50 to 60 degrees and hit the interlaminar space. So with the assisted USG, epidural insertion becomes more easier. There is faster epidural placement, reduced needle passes, reduced attempts, accurate level identification, and more effective working epidurals and better pain relief. Second technique of regional anesthesia for high risk patients is paravertebral block and erector spinal block. I will go with first landmark guided technique. Here, as we have seen, once we mark the midline, means we point, identify the midline, the spinous process, around 3 centimeter lateral to the spinous process. Our needle insertion will be there. I use normally 20 gauge blunted spinal needle, and once we have moved away 3 centimeter away from the spinous process, a needle is inserted, go straight, we hit the transverse process and then walk over it either cephalad or caudate, and you will get a pop-up. That is the way we insert. It is the giveaway is because of we enter the supracostotransverse ligament and you are into the epidural space. The volume injected is around 5 to 7 ml at each level. So this is how the landmark guided technique is the way we give. So during USG, with the help of USG, we can also do this give this paravertebral block effectively. There will be less complications. So coming to thoracic paravertebral space. So anterolaterally, there is parietal pleura. Posteriorly, there is superior costotransverse ligament. Medially, there is vertebra and intervertebral foramina. And superiorly and inferiorly, there are head of the ribs. So this is the space which we are talking about. So while giving thoracic paravertebral block under USG, a probe is placed around 5 to 6 centimeter away from the midline in the longitudinal axis, and it is moved towards the midline from 5 to 6 centimeter away from the midline, and then the probe is moved slowly towards the midline. You will see this structure which is now shown as transverse process. First it will be conical, and that is the rib. As you move towards the midline around 2.5 to 3 centimeter, you will see this structure becomes more square, which indicates that we have reached to the transverse process. And once that is identified, a needle is inserted from caudal end towards cephalent end under the USG guidance. What structure we go through? Skin, subcutaneous tissue, trapezius muscle, rhomboidus major muscle, erector spinae, and after we cross that all, we enter the thoracic paravertebral space. The needle trajectory will be like this from caudal to cephalad, and you under the USG guidance can safely put the injection exactly in the paravertebral space. Coming to erector spinae block, it is the same, but only thing is that if we give through landmark guidance technique, we hit the transverse process and we inject there. If under USG guidance, we see erector spinae muscle and just deposit under it. So it will be here. So coming to other technique, which is intercostal nerve block, it can be given by landmark guided as well as USG guided technique. Patient can be placed in prone or lateral position or sitting. So intercostal nerve, these nerves arise from ventral rama of spinal nerves, and they do have sensory and motor branches. So if the patient is placed in prone or lateral, around 6 to 8 centimeter away from the midline, a probe is placed in longitudinal axis and you will see the structures. The two ribs here, latissimus dorsi muscle overlying, and below if you see there are external, internal and innermost intercostal muscles, and below there is hypoechoic line which is pleura, which is a very important structure because we don't need to go inside, don't want to. So the neural trajectory direction will be from cephalad again to caudal with this angle, with little bit of angle, and under the guidance of USG, we enter the space. We try and go towards the superior rib. Our angle is towards the superior rib, and we enter into this space. If you see, this is the needle trajectory here, crossing trapezius, rhomboidus, internal intercostal, external, and here we inject. So this is internal intercostal nerve block. So the one more technique is there, serratocentric plane block. This provides analgesia to the lateral chest wall by targeting facial planes around the serratus anterior muscle. So SAPB involves injecting a local anesthetic into the facial plane, either above or deeper to the serratus anterior muscle. And this block effectively anesthetizes lateral cutaneous branches of all intercostal nerves, offering pain relief to rib fractures and all the thoracic procedures. Here we place the probe in around at the fifth thoracic intercostal space like this, and our needle will be going like this. If the patient is lying down in supine position, in lateral position, you can even go from posterior to anterior aspect. And once you place the probe like this, you will see the structure, the two ribs. Here you see the overlying serratus anterior muscle, and above it is the latissimus dorsi muscle. So needle if comes from this angle, you will deposit it here. It will be a superficial serratus anterior plane block. And if the needle is passed little more deeper, then it will be a deep serratus anterior block. Ideally, both blocks has to be given. I always give both the blocks for the adequate analgesia. And the hydrolocation, either with the local anesthetic or with the saline, confirms our needle tip and minimizes the complications. Here you see patient in lateral position and injecting from lateral to medial side. And here you deposit the local anesthetic. This is the superficial. And if you deep inject little more deep, it will be a deep serratus anterior muscle block. So these are all facial plane blocks. Ideally, I don't give these facial plane blocks for achieving anesthesia. I do use them for plain analgesia technique. Coming to pectoralis nerve block, there is PEC 1 and PEC 2. If the local anesthetic is injected between pectoralis major and minor muscle, it is PEC 1 block. If it is injected between pectoralis minus and serratus anterior muscle, it is PEC 2 block. It does block intercostal nerves, and PEC 2 block does also help in blocking long thoracic nerve and intercostobronchial nerve. So here we place the probe actually in the mid-clavicular line, mark the first rib, then slowly move down towards the third rib and move the probe from transverse to longitudinal and little more anticlockwise. The caudal end will become more anticlockwise. So if I place the probe like this, little more anticlockwise, and you will get this image on UHG. So here you see the third rib. You will see the overlying pectoralis major. Below it is pectoralis minor muscle, and below is serratus anterior. So if my needle comes like this between pectoralis major and minor muscle, the PEC 1 will be the block, and you go little more deeper and deposit just below the pectoralis major muscle, it will be PEC 2 block. So this is the needle direction. With these blocks, you achieve analgesia and anesthesia adequate for all the thoracic procedures. For intercostal nerve block, I normally inject around say 5 to 7 ml of local anesthetic. For PEC 1, PEC 2, around 10 to 20 ml of local anesthetic. And for serratus anterior plane block, around 20 to 30 ml of local anesthetic. So my takeaway message today is regional anesthesia for thoracic surgery is safe and effective technique for all thoracic surgeries, which avoids complications associated with general anesthesia and reduces morbidity. There is early recovery with lesser hospital stay. And USG application in anesthesia practice is necessity and should be practiced by every anesthesiologist for the benefit of the patient. We should not forget our old friend peripheral nerve locator, and it does have play a big role now also. With the help of USG and peripheral nerve locator, the accuracy is much more. Landmark guided paravertebral block. I'm playing the first video. So here I have marked the midline around 3 centimeter away. I am giving first local anesthesia here. So this patient, 74-year-old patient, he was diagnosed with lung cancer and he had bilateral pleural effusion, and his PFT was very, very poor, and we needed to drain those effusion fluid, and we did that under paravertebral block. So here now I have used my 23 gauge, but nowadays I use 20 gauge spinal needle, and it is blunted, and now I have just hit the transverse process. My needle is not going forward, so I have just angled it and I am into the paravertebral space with a loss of resistance. So here I have injected. So injecting at multiple levels helps us, be assured that it has acted uniformly all over the thoracic region. I do give single injection techniques, but that is only with I'm giving it for analgesia purposes. So the technique is GA along with PVB. But if it is only under paravertebral block, I prefer giving the injections at all the levels. So this is I have given at all the levels. This patient had was on low molecular weight heparin also. He was on ecospirin and clopidogrel, and he had undergone bypass surgery just 2 years back with ejection fraction of only 20%. So I did not want to give thoracic epidural in this patient particularly because he was on anticoagulants and chances of epidural hematoma are very high, as we all know. But along with that, there is one more thing, that in thoracic epidural anesthesia, there is not much hypotension as we see in general anesthesia, but definitely there is fall in blood pressure. With paravertebral block, there is only one-sided sympathetic nerve, which is sympathetic blockade. So the other side of the body, sympathetic system takes over, and the blood pressure which falls is not much. Second video I'm showing is of thoracic epidural insertion. So patient is in lateral position. This patient I had given general anesthesia. As routinely I give general anesthesia along with regional anesthesia. It does reduce the requirement of general anesthesia. All the medicines which we require for general anesthesia are the requirement is reduced. So this is how I have placed the epidural in T4-5 level. Putting the thoracic epidural in lateral position is cumbersome, and it is has its own challenges. As we all know, the curvature of the spine changes, and then marking the midline and just going, there are high chances of we entering the opposite side. As I said, the angle sometimes gets more acute, and but with practice, sometimes when there is patient is denying the needle prick before induction, we have to give the epidural in lateral position. So, introduction of USG in anesthesia and use of it in anesthesia is in a larger scale. I would say if everybody is used to giving all the blocks under USG, it does reduce the complication, and USG has big role in anesthesia. Thank you.